So now I'd like to introduce our next speaker. His name is Dr. Eisen Liang from the Sydney Fibroid Clinic in Australia. He's the director and founder of the Sydney Interventional Radiology. He's an interventional radiologist at the Sydney Adventist Hospital. He's a senior clinical lecturer at the University of Sydney Medical School. His clinical and research interests are in gynecological intervention, such as embolisation for fibroids, adenomyosis, and pelvic congestion syndrome. He has published a series of peer-reviewed papers on uterine embolisation and presented a series of abstracts in international radiology congresses, such as the European Society of Radiology, and he has over 20 years experience in uterine artery embolisation. Dr. Liang, the floor is yours, and it's an absolute pleasure having you here today on his lecture entitled Adenomyosis, a potentially missed, neglected, and inappropriately managed condition. Thank you, Dr. Liang.
Thank you, Shavo. Can you hear me?
We can hear you very well.
Yeah, can you see my slides?
It's perfect.
Thank you so much. Thank you, Gobei, for organizing this fantastic series of radiology and interventional radiology webinars, and this is really great, and I feel so privileged to be speaking to more than 400 attendants this evening. So this topic, adenomyosis, a potentially missed, neglected, and an inappropriately managed condition, is the same topic I've used for more than 10 years. So it is still true today. We just need to raise the awareness of this disease. And so I will start with what is adenomyosis. And it is the presence of ectopic endometrial glands and stromal tissue in the myometrium and an associated reactive myometrial hyperplasia. A lot of people know about endometriosis, and that's the same lining tissue that's outside the uterus, and but when it's inside the uterine muscle wall, it is called adenomyosis. That's glands in the muscle. So you have increased surface area for bleeding, and so therefore these ladies can have severe heavy menstrual bleeding that can be very debilitating. And when the glands are trapped inside the myometrium, they can have severe period pain. And as the gland develop during the second half of the cycle, they quite often complain about severe bloating symptoms, premenstrual symptoms as well. This is often neglected in the past because not too long ago, we didn't have a good imaging diagnosis for adenomyosis, and there wasn't any good treatment until in the last probably 2 decades. Even to date, we found that ultrasound, transvaginal ultrasound in our local area can miss up to 71% of the cases. As I said, there's no good treatment in the past, and hysterectomy is often offered as the only cure for this condition. And even today, many of my patients come to me have been through quite a few gynecologists and being told that hysterectomy is the only solution. Now, without the correct diagnosis, quite often these patients are put through many unnecessary surgeries. And for example, thinking that they might have endometriosis, and so they had a laparoscopy looking for endometriosis, and yet if the symptoms also includes heavy menstrual bleeding, they really should be thinking about adenomyosis. So hysteroscopy may have been done with DNC, trying to look for causes and offering treatment for the heavy menstrual bleeding. And if the underlying cause is adenomyosis, hysteroscopy DNC is not going to help. And I've also seen many disappointed couples that have paid, and in Australia, it's about 8,000 Australian dollars a cycle for IVF. Quite often they have many cycles of failed IVF cycles, not even knowing they have underlying adenomyosis, which can have a negative impact on their fertility and pregnancy. Adenomyosis is actually not rare. It can be found in 40 to 70% of hysterectomy specimens. It can cause debilitating heavy menstrual bleeding and severe period pain, and therefore it is important that we as a diagnostic radiologist will pick this up as early as possible. If we miss the diagnosis, and the patient can very much likely to be treated and inappropriately. Now, as interventional radiologists, we have this powerful tool of MRI that can significantly improve the diagnosis of adenomyosis. And we do have a very effective and safe treatment for adenomyosis, which is UAE. So as an IR, we can develop a service line alongside of UFE, working up our patients and discuss treatment options and perform UAE as well as long-term follow-ups for these patients. I just want to say that April is the Adenomyosis Awareness Month, but certainly in Australia, we have not seen much of this mentioned in the mainstream media. I think we are all swamped by the COVID-related news, and the health journalists are all very busy talking about COVID. But this is very much an important issue, a woman's health issues, and that we need to address. The aim of this talk is to understand the clinical aspect of adenomyosis, for us to be familiar with all the treatment options available to our patients, and to help our patients to decide on the best treatment option depending on their circumstances, and to learn how to take clinical ownership in the management of adenomyosis. It is important to understand that adenomyosis is not a single disease. It is a spectrum of disease. It is, and therefore can be a challenge for transvaginal ultrasound. When adeno is mild and superficial, ultrasound may not detect anything abnormal. When it's diffusely involving the uterus, all the ultrasound can see is perhaps just a bulky uterus and some heterogeneous myometrial echo without specific lesions that you can point your finger at. When you can point your finger at some focal lesion, they are quite often mistaken as uterine fibroids. And of course, when the adeno is involving the subserosal surface, they tend to merge with deep infiltrating endometriosis, and that is a challenge to diagnose, and quite often sonographers has to be specially trained for the detection of deep infiltrating endometriosis. This is a typical ultrasound appearance of adenomyosis. This is the endometrial lining. First, you notice is the asymmetrical thickening of the uterine wall and the typical venation blind artifact. MRI is actually a lot easier to spot the abnormality. You can see the direct sign, which is the presence of abnormal endometrial glands within the myometrium, and associated reactive myometrial thickening, which is hyperplasia and hypertrophy of the adjacent myometrium. Is often seen as thickening of the junctional zone. And this is what the normal junctional zone should look like after UAE. As I said, when it is focal, ultrasound is sometimes challenging to tell what is adeno or fibroid, and yet on MRI, it's quite easy. It is a view-defined infiltrative lesion with the typical T2 hyperintense foci indicating presence of ectopic endometrial glands. When there are multiple fibroids, it is difficult to detect the adenomyotic changes on ultrasound. This is a case of a 40-year-old cardiac nurse. She's been suffering from severe heavy menstrual bleeding and period pain for more than 20 years. She had multiple myomectomy, laparoscopic, hysteroscopic, DNC procedures, and she just have recurrent menstrual issues. Not until this MRI was done, she did not know for over 2 decades that what she's suffering from was actually adenomyosis. And these fibroids are quite often just bystander fibroids. You can see irregular thickening of the junctional zone. You can see fluid level in these 60 spaces. So it is quite challenging for ultrasound to differentiate between focal adenomyosis and uterine fibroid, and yet on MRI, this is very easily distinguished. Now, as a diagnostic radiologist, we see cysts in many organs every day. You can have liver cysts, renal cysts, pancreatic cysts, and they are usually rather benign conditions. Benign meaning, not causing any significant clinical concern. Yet, we don't expect any cystic changes within the uterine muscle wall. Remember, it is a muscle organ. We don't have epithelium inside the wall. We don't have endometrium in there. So when you see a cystic lesion within the uterine muscle wall, it is actually diagnostic of adenomyosis. And this is so-called cystic adenomyoma, and the Japanese has described this as juvenile cystic adenomyoma, but we certainly have seen this in women in their 30s and 40s as well. They're not confined to young women. This is a case to illustrate the importance that we make the diagnosis right. Now, this is, of course, an MRI of a very extensive adenomyosis infiltrating the whole uterus. This case was referred to me because the surgeons was trying to remove a so-called fibroid that was reported by the ultrasound, saying that this lady has a large fibroid. They spent 4.5 hours trying to resect this fibroid without success. They closed the patient and sent to me, say, can you embolize this fibroid? So until this MRI was done, we did not know that this lady had an infiltrative, a diffuse adenomyosis throughout her uterus. It is not fibroid. So making the wrong diagnosis can have significant implication in the patient's management. On paper, ultrasound doesn't look too bad. MRI is only slightly better than ultrasound, but that's not real world practice that I have seen in my locality. Now, the reason that ultrasound is not too bad, my interpretation is that these numbers are usually from academic units with special interest in the adenomyosis, and therefore these numbers are rather high. I guess it is possible that we improve our skills, and if we are aware of what we're looking for, we can perhaps achieve these numbers with transvaginal ultrasound. Now, what are we looking for in transvaginal ultrasound? Now, the most sensitive sign is just heterogeneous myometrial echo texture. And sometimes we can see these subendometrial echogenic linear striations. That is said to be with the highest specificity. The uterus is usually described to have a globular appearance rather than a slender pear appearance. So it is bulky, it is plump. And certainly look for this cyst. If the cyst is present, the diagnosis is made. So here's the signs again: asymmetrical wall thickening, venation blind artifact, linear striations. They're quite subtle, but they're said to be very specific. Myometriosis, very specific. Hyperechoic islands in the myometrium. Focal mass, and that's difficult. I have difficulty with that, and to tell whether it's fibroids or adenomyoma on the ultrasound. And this one, I also have difficulties myself, irregular endometrial myometrial junction. And I found it quite hard to use this sign. So for me, I look for this cyst, asymmetrical wall thickening, venation blind artifacts. Now, how can we come to a Gorbet-sponsored and organized seminar without talking about HSG? Now, this is in the old days when we are doing diagnostic HSG, and even nowadays, you might see this like outpocketing of the contrast representing diverticuli in the adenomyosis. Now, this is a modern day appearance of the same thing. When you do an MRI, you see these pockets of high T2 signal as within the myometrium. So the abnormal glandular tissue in the myometrium. A few words about junctional zone. And quite often you don't see those high signal glands in the myometrium. All you see is thickening of the junctional zone. Junctional zone represent a closely packed smooth muscle cells with very little extracellular matrix and water contents, and therefore they are dark in T2 weighted sequence. So the normal junctional zone is said to be less than 8 millimeters. Up to 12 millimeters and above is said to be diagnostic of adenomyosis. But quite often, if you have a very small uterus, then the absolute thickness does not make sense. So another criteria that you can use is that the junctional zone is more than 40% thickness of the total myometrial thickness. As you can see, here is normal junctional zone, and here you have thickening of the junctional zone in the fundal region of the uterus. That's before and after UAE. Next, I'm going to talk about treatment options for adenomyosis, and this is particularly important for people doing interventional radiology and performing UAE for adenomyosis. It is important that we understand fully the clinical aspect and all the treatment options when you discuss with your patient. First of all, I would like to talk about those surgical options first. And because this is an infiltrative lesions, as you can see, unlike fibroid, they can be easily removed or enucleated. Because this is an infiltrative lesion, adenomyosis is generally considered not a surgical lesion because of absence of surgical plane. It is just not possible to resect. You either resect too much, and then you're losing too much normal myometrium, or you under resect and recurrence will be a major issue down the track. The next thing I want to talk about is ablation. Quite often when the uterus looks normal on ultrasound, and if the patient suffers from heavy menstrual bleeding, and this is quite often offered as an alternative to hysterectomy by the gynecologist. It is important that we pick the diagnosis, we make the diagnosis of adenomyosis, because if you apply the endometrial ablation to someone with adenomyosis, the heat energy is going to destroy that layer of endometrium, and it's going to seal off more glands, and you're going to trap more glands inside the myometrium, and quite often the patient come back with a worsening of their period pain. So to me, personally, in my opinion, endometrial ablation should be contraindicated in patients with adenomyosis. In fact, we have treated quite a number of patients with post-ablation pain using UAE and achieving a good pain relief. Now, hysterectomy is still offered routinely by gynecologists as the only cure for adenomyosis. But is this still true in the 21st century? It is a major surgery and requires 3 to 5 days in hospital and 4 to 6 weeks of recovery. And therefore, it is associated with major complication of any major surgery. Even in 2019, it was said that the severe complication rate from a hysterectomy ranges between 3.5 to 11%. Even in advanced country in Australia, like from Melbourne, Australia, the reported mortality rate from hysterectomy is up to 1.5 per thousand. So it is not exactly low. Doesn't matter how good the surgeon is, and doesn't matter which mode of hysterectomy that is performed, the long-term side effect cannot be avoided. That is well known, such as prolapse and incontinence. And we know that hysterectomy can bring forward menopause by 4 years. And this is important. Coronary artery disease, 2018 Mayo Clinic study has confirmed that there is increased coronary artery disease by 33% in women who had a hysterectomy, but with your ovarian conservation. Even you keep your ovaries, you still have increased coronary artery disease. Other long-term side effects include change of sexual function, constipation that's probably related to nerve damage. And so there are long-term side effects of hysterectomy. Now, having talked about this surgical management, we're going to talk about some of the good treatments that we, and as interventional radiologists, can offer the patients. Now, quite often the medical therapy might have been offered by the GPs already, but we still need to make sure the patient has tried this and as the least invasive therapy. Tranexamic acid is an antifibrinolytic. We use this in trauma, we use this in childbirth, and we use this in surgery. It is prothrombotic, so nowadays it's hard to convince women to use these drugs because of so much clotting news associated with COVID-19 vaccination. It should not be used as a long-term solution, and because of the potential risk if you use it long-term, and certainly it is contraindicated in women who had previous history or having a high risk of developing arterial or venous thromboembolic disease. Non-steroidals, they are good for period pain, but it is important that the patient take this drug before the period come to inhibit the prostaglandin production. And it is also mildly effective to reduce the heavy menstrual bleeding as well. And other medical therapy are hormone manipulation, using progesterone either in a cyclical fashion or continuously, or use it to arrest acute hemorrhage. And the issue with progesterone orally is side effects with breast tenderness, acne, weight gain, bloating, moodiness, migraine, and some of them develop breakthrough bleeding as well. Quite often in general practice, and they like to use combined oral contraceptive pills and to regulate the periods. And however, there's no specific studies that OCP reduces heavy menstrual bleeding in the setting of fibroids and adenomyosis. In fact, we not even know if the estrogen in the OCP can potentially worsen the underlying fibroids or adenomyosis. The next thing we need to know is the progesterone IUD, and it leaches out low doses of progesterone over 5 years, and study has shown it is effective in controlling heavy menstrual bleeding as well as period pain. The problem is the side effect. 25% develop prolonged bleeding, 14% irregular bleeding, and there are other minor side effects such as weight gain, mood changes, ovarian cysts, abdominal pain, and acne. So it is important to know this number here. Overall patient satisfaction rate at 1 year is only 56%. This is a study from China, so I believe there's some audience from China tonight. A more recent study has shown that, and if the uterus is larger than 150 mil, and Mirena is unlikely to work, and in fact 70% will discontinue Mirena if the uterus is more than 340 mil. In other words, if the adenomyosis is more extensive, and Mirena is likely to fail. What about UAE? It is the same procedure as we do for UFE, but we tend to use smaller particles and achieve a harder endpoint. And so it is a local anesthetic, 1 night stay in hospital and 1 week recovery. And I will show you we have achieved 90% clinical success rate. And unlike fibroid that Professor Kim has talked about, and you can have all sorts of complications that usually related to submucosal fibroid, it is extremely rare occurrence for any sloughing or endocavitary migration of any significant tissue of adenomyosis. So it is a good procedure that with very, very low potential complications. You've seen this case before and after, and that one as well. And if it is even with a large focal adenomyoma, they don't seem to slough off. At most they get is occasional vaginal discharge. In fact, as far back as 2013, NICE Institute in UK has already recommended UAE as a potential treatment option for adenomyosis. And there are many, many studies, case series, as well as a couple of meta-analyses. Basically, the number to remember is that for pure adenomyosis, long-term success about 75%, and combined fibro and adeno, the results is even better. And actually, most of the patients actually have both conditions coexisting. So you're actually getting a better long-term result up to 85%. And we published our case series of 117 cases in 2018, achieving 90% overall patient satisfaction rate. And our hysterectomy rate is only 5%. And it is quite good for pain relief, a pain scale drop of 6 points in our patient cohort. So IR, we can, it's important that we take clinical ownership to work up the patients and check the irons, check the full blood count, organize the MRI to confirm diagnosis. And it's important that we follow them up as well, and to manage the post-embolization syndrome, and to manage the expectation that we do not have a 100% success rate. If they have any residual symptoms, we should consider add-on therapy with tranexamic non-steroidals, even Mirena insertion, which might not work before, but after embolization, Mirena might work quite well. And sometimes they do need more than one embolization for this giant adenomyosis. and one embolization may not achieve desirable clinical outcome. The time's running short. I just want to say adenomyosis have negative impact on fertility and pregnancy, as well as negative impact on IVF outcome as well. So this is important to make the diagnosis, and especially in subfertile couples, so that they know the options. And the treatment is to use GnRHA to recondition the uterus before frozen embryo transfer. That probably gives the patient the best chance. At the moment, we don't have enough data to support the use of UAE for adenomyosis. But one thing we can tell them, if they fail all the other treatment options, and if hysterectomy is their only other solution, then we tell them that there's 1 to 3% chance of ovarian failure rate for women younger than 40 years of age post-UAE, and there's more than 90% chance they get to keep the uterus. So thank you very much for your attention. And this book has just been released and it's available on eBay and Amazon. And the ebook version will be out in the next few days. I know there are, looking at the names of the participants, we have people from all over the world. So if anyone's interested in translating this book into a language, please contact me and we can discuss that. Thank you very much for your attention.
Thank you very much, Dr. Liang, for that excellent presentation. And now I would like to call on both speakers, Professor Kim and Dr. Liang, please stay for our Q&A session now. Professor Kim, if you could turn your camera on, please, and your microphone, that would be great.
Can I, while we're waiting, can he hear us? I don't know.
I think he's coming online. Yes, please go ahead, Dr. Liang.
Mandu, can I ask the question about cervical fibroid? And it is a headache for us. So you're saying that we should do selective embolization of cervical vaginal artery. Should we be doing that bilaterally, or would you be worried about vaginal ischemic injury if I do bilateral super selective embolization with small particles?